Hello friends, welcome back to my channel with a new video, and this is part 3 and the final video on weaning, and let us continue that further. So uh, difficult to wean patient when the first SBT fails. Of course you go to multiple spontaneous breathing trials, and there if you have three spontaneous breathing trials uh, which gets failed, or there are 7 days within the 7 days, then of course these patients are to the tune of about 26 to 39%. So about 40% of the patients would be labeled as difficult to wean patient, and the moment they cross the duration beyond 7 days, the risk of the death as well as the extubation failure increases. So this is something called as a WIN classification, where group 1, where the first attempt of weaning and the termination of the weaning process within 1 day. So this is group 1, which is a short weaning. Group 2 is difficult weaning, where the termination of the weaning process after the first day but within 1 week. So when the patient gets weaned off maybe within a week's time, it would be about a difficult wean patient, and a prolonged weaning patient where the weaning is continued beyond 7 days. So here again it is subdivided as group 3A and 3B. So it's a very famous paper published in ARJCCM in 2017, and this is a WIN classification. As far as the duration of weaning trial is concerned, the standard duration is anywhere from 30 minutes as a minimum period to about 2 hours. So it is not necessary that you continue the TPs or SBT for 4 hours or 6 hours, and it is a common misconception that 2 hours can be a very small time, but many studies and the evidence supports weaning trial to about 2 hours. And when the mechanical ventilation is beyond 10 days, then in few situations you may find that the SBT is prolonged, as I said, beyond even 2 hours, but by and large it is 30 minutes to 2 hours. And when there was one study which compared the SBT for 30 minutes versus SBT of 120 minutes in terms of weaning failure or reintubation rate, the numbers or the findings were identical. So this is how it is. And when you have COPD, mechanical ventilation, of more than 15 days, then the SBT failure, where it was labeled as SBT failure when the TP's trial or SBT was given beyond 120 minutes. So this is a very important kind of information which we need to understand as regards the duration of weaning. And it is a misconception that you continue the TPs for 6 hours, 8 hours, 12 hours. It is not required except in few situations, as we discussed. Another extremely important bedside clinically relevant concept is of extubation to NIV, and they take into account the mortality, the VAP, the mechanical ventilation duration, the tracheostomy rates, and the reintubation, which was the data published in Cochrane database in 2010. And the conclusions were the extubation to NIV has to be considered in the patients of COPD without any difficult airway, with less secretions, and with a good mental status. So these are the 4 important conditions where extubation to NIV has to be considered. In terms of automated weaning, we need to adjust the pressure support levels and monitor the respiratory rate, the tidal volume, and the carbon dioxide. And if the patient is stable on the pressure support, you can actually decrease the pressure support. So there was one study, and again published in Cochrane database, which took into account the 21 RCTs all together, and this was like a database. So this is a huge data with about 1600 patients, which took into account the duration of mechanical ventilation, the ICU length of stay, the mortality, the benefits of the weaning, and the harmful effects. And uh, the problem here is that the ICU population is heterogeneous. As we know, no two patients are identical. Every every patient is different in its his own sense. So this is one challenge, and it is of course not applicable for pediatric patient or the patient with respiratory acidosis with PCO2 of more than 60. As far as weaning index are concerned, uh, we take into account tidal volume, the frequency, the NIF, that is negative inspiratory force, uh, the vital capacity, the minute ventilation, and of course, it is by the formula RSVI multiplied by EI, that is elastance index, multiplied by VDI, or ventilator demand index, and they are readily available on the net online, and anyone who is interested can actually go and search these. But the very important factor which probably we can discuss is whether there is any role of POCUS in weaning, and here we are talking about the thickness fraction, the diaphragmatic thickness fraction to be specific, as a weaning index, and this is a cutoff of more than 36%. So if you have a diaphragmatic thickness fraction of more than 35 or 36%, then you have a high likely possibility that the patient can get weaned off. And of course, you have you have this kind of formulae for the same, where you put a probe in the zone of apposition, where you see the excursion of the diaphragm happening, and as you could see that the diaphragm is thicker in at the kind of end of inhalation, and it is thinner at the end of expiration. So it is easy to identify as to which phase of the diaphragm that particular section of the diaphragm is in, and it is classically seen in mid-axillary line in 8th to 10th intercostal space. You put a M board in that, and then this is the formula to calculate that fraction, which goes by the thickness of the diaphragm at the end of the inhalation minus the thickness of the diaphragm at the end of exhalation, that is expiration, divided by the thickness at the end of expiration multiplied by 100. So my dear friends, remember this formula for calculating the diaphragmatic thickness fraction, and remember the figure of around 35 to 36%. If it is more than that, then there is high likelihood that the patient might get weaned off. At the same time, you can also have the diaphragmatic excursion, and this is as you can see that this is the end of inspiration and this is the end of the expiration. So this red line is the kind of, there is an excursion, as you could see. So if the diaphragm is moving in between inspiration and expiration more than 10 millimeters, that is more than 1 centimeter, then probably the movement of the diaphragm is adequate and the excursion is adequate, and again the cutoff is around 10 millimeters. If it is more than that, then your patient has high likelihood of getting weaned off. So these are the two very important aspects of POCUS in weaning. As I said, this is the excursion, and ultrasound determines the diaphragmatic movement to identify the diaphragmatic dysfunction. It also actually sees the thickening, as we have discussed. So recovery from the diaphragmatic fatigue, if you see that this is the baseline, and the time passes maybe from the baseline to about 30 minutes and then 1 hour, and you have this duration say about 8 hours. The diaphragm takes about 6 to 8 hours for its function or for the recovery of the diaphragm from its fatigability. So it takes a lot of time. You need to actually focus about a good nutrition, whether the patients have received the NMDs, sedatives, whether there is supplementation of the trace elements, and nowadays we stress upon initiating vitamin B1, that is thiamine, straight away during first or second days, and don't wait for 4 or 5 days, and supplement the trace elements along with zinc, selenium, and chromium. So these are a few of the clinical aspects of the same. So this was a kind of a study presented by Kwan et al. In BMJ 2018, and there were about 11 studies which was taken into account, out of which 8 studies were studied the diaphragmatic excursion, and the 5 studies looked upon the thickness fraction of the diaphragm, and they found to have a good diagnostic performance to predict the diaphragmatic dysfunction, and it definitely had a direct bearing on the weaning failure. So as you could see that the diaphragmatic excursion criteria of about 11 to 14 millimeters. So by and large, if it is less than 1 centimeter, then of course there is a problem, and the thickness fraction of the diaphragm of 30 to 36%, it should be more than, so maybe about 30% also is okay. It has a good sensitivity and specificity, and we should have a practice of assessing these two parameters, especially with the help of ultrasound machine, for the patients who are on ventilator and getting weaned off. So there should be a weaning protocol, as I was saying. It should be a structured weaning protocol, taken into account the risk factors, the sedatives, the sedative interruptions, the restrictive fluid strategies, usage of NIV as much as possible, and so on and so forth. And this we discussed. So definitely we need to have few formulas in place, and the weaning trial to be scheduled. There should be a protocol which is written in the form of whether you have a TPs, use of pressure support of say about 7 centimeters, the CPAP of about 5, and then of course you run this protocol. And it was shown that the protocolized weaning will definitely have a major impact on the successful weaning of the patients from your ICU. So my dear friends, this is my last slide, and I think I'm giving you a few takeaways, but here I have said that you don't take it away, please keep it in your brain. So when the weaning should be thought of, it should be thought as soon as possible when the patient goes on ventilator, whenever possible. What do you mean by weaning? And we have seen the difference between what is weaning and liberation. What is the definition of weaning? What is the definitions of the simple weaning or the difficult weaning, and the different types of the terminologies. Why it is important? It is very clear. We need to decrease the morbidity, the mortality, the ICU length of stay, and speedy recovery of the patient. There are various ways as to how you do it, that is been discussed, and when not to do it has also been touched upon. What are the various classifications, and we saw the various modalities with which it is done. What do you mean by weaning success and weaning failure, and the signs of the same? What are the criteria of extubation to NIV, and that is what is been discussed in detail when we discussed about those. And of course, don't forget POCUS. And nowadays we have a very routine practice of assessment of the diaphragmatic excursion with a cutoff of about 10 millimeters, and diaphragmatic thickness fraction calculation with a cutoff of about 30 to 35%, and if it is more than that, we have a good chance of weaning for those patients. So I hope all these 3 videos and weaning would throw some light and would be of some benefit to you in your day-to-day practice. So that's all for now. Tata, bye bye, take care.